Hello and welcome to another intensivecareathome.com podcast. I want to share a podcast today with Kaneez Hakim, who's our New South Wales service manager. Hi, Kaneez.
Hi, Patrik. How are you?
Very good, and thank you so much for coming onto the call. Now, before we go and have a bit of a conversation about intensive care at home and about New South Wales, I just quickly want to introduce our listeners and viewers about what we do at intensive care at home. We provide services at home for predominantly long-term ventilated adults and children with tracheostomies. We also provide services at home for other medically complex clients, such as adults and children that only have a tracheostomy but still need 24-hour ICU nurses at home, or for clients that are on BiPAP, CPAP ventilation at home. We also provide services such as home TPN, intravenous nutrition, and we also have now recently started with IV potassium infusions at home, or IV magnesium infusions at home. So we're pretty much covering everything that needs a critical care nurse at home. That also includes us now sending critical care nurses for the Sydney Western local area health district. We're basically providing an emergency department bypass service for a big health service in Sydney. So, you know, if you're watching this and you have a family member in intensive care, or you are a hospital executive and you're thinking, okay, how can we manage our resources better in a hospital? You should definitely reach out to us. If you are an NDIS support coordinator and you're looking for nursing care for your participants, you should also reach out to us. And if you're not sure about the funding with the NDIS and the nursing care side of things and the advocacy, please reach out to us. We can help with all of that. So without further ado, let's talk about Kaneez and what we do in New South Wales. So Kaneez, you've just recently started with us in a new position as our New South Wales service manager. I want to thank you for that, for joining us in that position. You've worked for us, you know, for the last 2 years with our clients in New South Wales. Anyway, can you share a little bit more about your nursing experience and what led you to us?
Yeah. So I've been a nurse. I've pretty much stayed in the intensive care field. I did adults for a good 8 years. And then when I moved over to the US, I ventured into pediatric ICU. And then I was doing pediatric ICU for about 11 years. We came back about 5 years ago, and I've just kind of been doing casual shifts in neonatal ICU. So even though I've stayed in ICU, I've sort of just done the whole lifespan. What brought me to you? Well, interestingly, I wasn't looking for a job. However, my mum was at the end of her life in an ICU out here west of Western Sydney. And, you know, we've seen it multiple times. I'm sure you can agree. You know, it's the middle of the COVID pandemic. It's the end of her life, but unfortunately, the way it played out, she ended up having to go to ICU, but she dropped to GCS, and no one knows why. I mean, I personally believe that she was done. So I'm sitting in the middle of the ICU during a COVID pandemic. They've made my mum palliative care. There's no palliative care beds. And I'm just thinking, this is just terrible. Like, and I know I've done this for families often, but we could at least put them in a private room. But with COVID, all the private rooms were full up. But I just remember she dropped to GCS on a Friday night, and I just thought, oh, you know, I want to see the palliative care team. I want to take her home. And they were like, no, you know, she's got a palliative care bed, and palliative care team doesn't work on the weekend. Okay, sure. So, you know, over the weekend, and, you know, it is the middle of the pandemic, and so family can't visit. My sister, myself, and my dad had to visit every other day. Not every other day, but like only one person could visit at a time. So, you know, and I guess maybe I was talking about palliative care. You know, I know they say phones don't listen to us, but I don't believe that. Your ad came up, intensive care at home, and I thought, wow, this is interesting. I mean, it was a little bit foreign to me because I think when I first spoke to you, I was like, oh, I think I may have applied for the wrong job because I really wasn't looking for another intensive care job. I wasn't looking to go work at another intensive care in New South Wales. You know, I mean, I've done enough of it.
Not during the pandemic anyway.
Not during the pandemic anyway. Yeah, exactly. So, and you were like, no, we provide this at home. And I was like, oh, okay. Like, you know, I know I had read it like that, but obviously, you know, I wasn't in the right state of mind anyway. But it popped up on my social media newsfeed. And that's essentially how I started with you guys. But yeah, because I remember thinking, oh, geez, you know, if I could just take her home now. I did. I took her home on Monday, first thing in the morning. I told the palliative care doctor, and I want to take her home. And he was like, well, she's probably going to pass away very soon. I was like, that's fine. I still want to take her home. You know, I think that's what my mum wanted. That's why she didn't pass away on Friday night. She stayed around and she lasted another week. And, you know, it wasn't full lockdown. So her brothers and sisters could visit her. Like, I think, and it really is interesting because when we went to the intensive care conference in April, you know, I sat through all the end of life stuff, and they had said that 25% of families whose patients die in an ICU suffer from PTSD. And I totally see that because I was able to provide my mum the care she needed at the end of her life in the comfort of her own home. I was able to provide the help that the extended family needed, her brothers and sisters, because they wouldn't have been able to see her in hospital. That was like a strict no for the hospital, that it was only my sister, myself, and my dad that could visit. So it's like, I get why there would be PTSD because I've seen the deaths in ICU, you know, noradrenaline maxed out, adrenaline maxed out, black hands, you know, you're still coding someone, you know, it's just like, you know, till their last breath. And it's just, it's just like, you know, even now when I talk to people about my experience, because honestly, like, my death experience with my mum was amazing. It was amazing. It was beautiful. That's what I can say. And when I tell people, you know, especially other nurses, because you think, well, nurses, even if they were in hospital, they'd be able to provide some care. I had one nurse turn around to me and say, I would work with her at the NICU, and she was like, it's been 27 years and I'm still extremely angry. And I thought, wow, 27 years. And when she thinks about her father's death, she has a lot of anger still. And I thought, you know, a service like ours could just change that trajectory.
Thank you, Kaneez, for sharing that, because I think it's extremely personal what you're sharing here. But I also think it's beautiful that you can share that. And I can see you're not traumatized.
No,
you know, you're not traumatized. You know, you would have been traumatized if you hadn't taken her home.
No, exactly. And I mean, it's even little things like, you know, I'm the youngest, so I probably wasn't the one that listened the best. But to be able to provide my mum what she needed at the end of her life really gave me a sense of, whatever happened in our lives, whatever, you know, distress I may have caused her as a teenager, I've kind of made up for this now. Like, you know, it's just like, it's a whole, like, it's just, yeah, you get peace if you get to bring them at home. And just death in itself was actually really beautiful. Like, it was calm. You know, yeah, there was the death rattle at the end, but I knew about that. Being a nurse, you know, I was able to keep everyone sort of grounded when that, you know, the non-medical people in my family, because, you know, and I was like, it's only agitating you. I promise it's not uncomfortable for her. And then being comfortable giving the medications, you know, and we did have palliative care come around, and you know, it was during the pandemic too, so they were very hands off. I don't know if it's any different normally, but you know, they came on the last day. You know, she'd been home for a week, and actually no one had even called. You know, I mean, I'm sure they provide what they can provide, but it's certainly not what families need to heal properly.
No, I mean, Kaneez, as you know, in our day-to-day work, we are dealing with so many traumatized families, and they have not gone through the end-of-life care stage, and they're still traumatized because of all their negative experiences in hospitals, in ICU over the years. They feel let down by the system. They feel not being heard. You know, the level of trauma we are dealing with on a day-by-day basis is, you know, it's almost unheard of. And, you know, you've seen both worlds, and especially with your pediatric and neonatal ICU experience, you know, you are used to, you know, probably diffusing stress, diffusing trauma. I know you're very good at that. You know, I've seen it, you know, diffusing stress, dealing with traumatized families. You know, I think that's part of your core skill, you know. But besides, sort of, obviously you've had that experience with your mom, you know, then you saw what we were doing, then we could obviously give you some work with some clients pretty quickly. Was it sort of what you expected in the end? I mean, you've seen, you know, the challenges that we are facing in a home care environment as well. Share a little bit about what it looked like in the end for you to work with our clients hands-on.
Yeah, I mean, I absolutely love being able to work in the community with our clients. I think, you know, there's so many buzzwords out there: person-centered care, family-centered care. You know, there's a national health and safety goal, partnering with consumers, but you can't do any of that in a hospital. Like, I'm sorry, if you're made to wake your patient up to bathe them, that is not person-centered care. If you have visiting hours, that is not family-centered care. And I truly felt what person-centered, family-centered care was when I went out in the community, because they are the driving force. You know, so many times, especially being an ICU nurse for 22 years, you know, you think of your patient as this empty vessel that you can just fill with information and education, and yep, lo and behold, everything's going to be wonderful. And that is so unfair, because it's not until you go out to the family life that you see all the other nuances. You know, when you have sick kids, their brothers and sisters are affected. You know, obviously mum and dad, you know, the divorce rates are through the roof with children with special needs, you know. So it's like you can actually provide what everybody needs, and the patient, because they get to be, if the, you know, and that's, I do kind of like that, you know, if there's something that we think, oh, it's evidence-based, we should do this, blah, 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 you know, they're just like, no, I've done it for 20 years like this, and it's not a problem. So why, you know, and I think it's like, yeah, because it works for them, you know. So it really does become person-centered, because it's not, we try and say, oh, this is the evidence, we're going to paint it on every single person that comes in, because it might not agree with a certain person, and they get to do it the way they want. So I really think now, after 20 odd years, I am now providing the best care I can to my patients, because they have autonomy and they are empowered to put forth their opinions. You know, I think, I'm not going to lie, I think in hospitals we say that, and, you know, patients say what they want, and then we're just like, okay, we did the checkbox of asking them, but we're not actually that interested in what they have to say.
No. Which is where the, from my perspective, which is where the trauma is coming from, that they've experienced. And, you know, you mentioned divorce rates, you know, when there's families with special needs children and so forth. And, you know, I do believe that over the years we have changed so many lives. I don't think it's an exaggeration when I'm saying we've changed lives, we've saved marriages, we've probably saved some people from poverty because they could no longer work, because they spend all their time in hospital, right? I don't think it's an exaggeration when I'm saying we've changed lives, saved families, you know, families from breaking down. You know, I mean, the flow-on effect from a family breaking down because of their complex needs child is living in ICU or in a hospital. I mean, it's just, you can't put this in words.
Yeah, and even building that trust, like, you know, once you have built that trust, parents are willing to actually go out and enjoy the day because they know their child or their loved one is safe at home. And, you know, you get to build that by being in the home all the time. And, you know, I think, yeah, just, you know, I've had one of the mums say, oh, it's just so nice to be able to just go down to the shop and not have to worry. You know,
100%,
yeah.
100%. It's, yeah, you know, and as much as I said in the earlier days when we started, you know, we save half of the cost of an ICU bed. Whilst that is true, you know, I don't think you can put a monetary number on the service that we're providing. It's, you can't weigh it in monetary terms, you know. Yeah. Okay, so obviously with that experience in mind, you've done, you know, you've had your own family experience, you've worked in ICU, you know, you've seen all the traumatized families, adults, and the pediatric side of things. Then you worked with some of our clients, you know, then obviously we were, you know, growing to the point in New South Wales where we thought, okay, now we need to take this further, you know, which is why we offered you the position as New South Wales State Manager, you know, and we, since you've started, that's been very busy, which is great, of course, you know, and yeah. People are finding the service, and that's really very positive, of course. You know, it's also positive with the developments that we are seeing with the NDIS, within the NDIS space. While the NDIS still has to go through a lot of improvements, you know, the foundations are there now, where we see that most clients that need ICU nurses at home can access that level of funding, you know, which helps them and obviously also puts confidence back into the community, where families can see, okay, well, my family member is in ICU, but at least here is an avenue to take them home, right? And the funding usually follows. And again, for anyone watching this, if you're wondering about NDIS funding, you know, you should contact us, or about any other funding for that matter in New South Wales. We are now also moving towards being a preferred provider for eye care in New South Wales. So eye care is insurance for motor vehicle accidents, for work safe and so forth. So if you're watching this or listening to this and you are an eye care participant, you should reach out to us as well. Now, Kaneez, with your pediatric experience in particular, I guess there's another sort of thing that you and I have seen firsthand in the last few months. When young teenagers, young adults transition from the pediatric world into the adult world, and they can no longer go back to pediatric ICUs because they're now technically an adult, we can see that the stress that's causing for families too, which is, again, rather than, you know, putting those kids, because for me they are kids, back into an adult ICU, which causes even more stress and angst, because adult ICU will treat those kids very differently compared to a pediatric ICU. You know, we've seen it firsthand now. You know, keeping those clients at home, we believe, alleviates a lot of that stress by transitioning from pediatric ICU to adult ICU, where, again, I believe our service is absolutely invaluable, you know, because we can keep them at home predictably. What are your thoughts, especially when for young adults or for, you know, 18, 19-year-old complex kids that are sort of on the verge of technically becoming an adult and going into adult healthcare? Is that going to work, or what's your experience there?
No, I mean, I don't think so. And, you know, time and time again, I think we've seen that it doesn't work because there is no transition. They call it a transition, but it's not really a transition. It's you're done with the peds service. Here's the adult service. Peds will send all the information over, but I don't think there's any collaboration. You know, they might sit down once, but there's no like ongoing collaboration for any other time that this person might enter the hospital again. They will be looked at from an adult lens, despite the fact that they're not adults. You know, sure, the number on the birth certificate tells us they're an adult, but, you know, there's so many other things at play, social, emotional, cognitive development. And there is no way you can tell me that sometimes these adults are still children. So, there isn't like it's just a handover. And so, it is quite
a 15-minute handover to go from the pediatric world to the adult world.
Exactly. And so going forth, if there's ever an issue that arises, I mean, I know definitely, it's like, well, why don't you call the peds world? This is what they did. And you can tell that they have no intention of doing that. No. It's like, well, our adult doctors have said so and so and so. It doesn't work. It would be better if the peds part collaborated with us.
Absolutely. And the reason I want to bring this up, Kaneez, is, obviously we know about a particular client there in Sydney, but we've also seen similarly aged clients here in Melbourne now time and time again, where the transition from the pediatric world to the adult world is just an absolute disaster. But here is the good news. The good news is that I think we can be a real conduit by keeping our clients at home predictably, so that number of hospital admissions are not there. They're not, we avoid them full stop, with very few exceptions, of course. But what we also do as a professional health service, we then liaise with, GPs, with specialist appointments, with the physio, with the OT, whatever needs to be organized to keep our clients at home. Because prior to the NDIS, when there was no funding, those kids would have bounced in and out of hospital all the time, again, putting family unity at risk. And, I think, yes, I'm tooting our own horn here, but the reality is that with 24-hour specialist nursing care, those clients are at home predictably. You don't need to worry about going back to an ICU, because we are bringing the ICU into the home, right? Here is another aspect, Kaneez, that I think is so important, for all of us that have worked in ICU for long times. The last thing that goes through a health professional's mind in ICU is community access. You're stuck in an ICU bed. Well, community access is a million miles away. Whereas in our world, every client, without exception, has some level of community access, which is, the best that can happen in an ICU bed is you might see the window, or you might
not even get a shower.
Might not even get, oh my goodness, Kaneez. Yes. Might not
9 months, you might not ever get a shower, just a bed bath. Yeah.
Yeah. So, little things that we take for granted on a day-by-day basis, like, sitting on the balcony, getting some sunshine or whatever, just taking a walk around the block, getting some sunshine, getting some fresh air, things that a healthy person takes for granted. Our clients probably don't, because they've lived in hospitals for months, for years on end, whatever the case may be. And then we're taking them home, and all of a sudden they have community access without exception. And that looks different for different people. For some of our teenagers, it might mean they're going to school, they're going to a daycare program. For other participants, as you're well aware, Kaneez, one client went to university.
Yeah.
Right. So, it's different, things for different clients. But the bottom line is this, that none of the community access would have happened if clients would have been stuck in a hospital.
Yeah.
It's way beyond, as much as we say we are intensive care at home,
it
goes way beyond that.
Well, it's a holistic approach, isn't it? Because these clients, if they were in hospital for 9 months, what's one thing the doctor orders? Oh, well, if it's possible, can we get them outside? I remember, this 20 years ago, the ICU I used to work at had a balcony, and these long-termers, they were all ordered, you'd have physio, OT, everyone, you'd get them in the chair and you'd get them outside for a little while on the balcony. So if that's being ordered in a hospital, it just goes to show how important it really is.
Absolutely. And it makes all the difference in the client's quality of life.
100%.
It's also like, again, if you are listening to this or watching this and you're an ICU professional, doctor, nurse, whatever your affiliation with ICU is, think, as much as it's a cliche what I'm saying now, think outside of the box, right? And think about the bed pressures that you are having in ICU on a day-by-day basis. You don't have enough beds, you don't have enough staff. We know all of that. We've worked in the environment long enough, to think about what is possible in the community. And you may wonder who's going to pay for it. We also know that many ICUs have no idea about the NDIS, that, NDIS funding can help with manage some ICU beds. Again, if you are an ICU professional, doctor, nurse, if you're a hospital executive and you're wondering, how can we manage our ICU resources more effectively? I really welcome you to reach out to us so we can have a conversation around how we can help you and help our clients. It's a win-win. Kaneez, I also want to quickly talk about coming back to palliative care. We have provided palliative care on and off over the years. Some of our clients, thank God, they could live for many years, could live for decades even, and others have come to us specifically for palliative care. Once again, you mentioned statistics earlier, 25% of families in ICU are trauma.
If a family member dies in ICU, 25% of the living family members have PTSD.
Right. Okay. I have another statistic for you. Apparently, 75% of people in the Western world, from what I understand, want to die at home if given a choice.
Yeah, and 75% of them die in hospital.
Correct. So there's definitely a mismatch.
Yes, huge
definitely
mismatch. Yeah.
Huge mismatch. You've also mentioned palliative care services in the community being hands-off. I can confirm that. And that, the palliative care services that we work with are very hands-off. That's not to say they are not of use. So the only thing we often need from them is someone to help us with pain management, right? So we need someone that, can change the medications if needed, especially when it comes to, pain management. Some of the palliative care clients we had at home were end-stage lung cancer. They were on BiPAP, for example. They needed pain control, of course, so that's when we definitely need a palliative care service. But also, as you're also aware, we are in the process of onboarding our own doctors. So we think, there'll be more input from our own people, which is great. But, just again, from an intensive care perspective, anyone watching this, whether you're a family, you might have a loved one in ICU, and you might be thinking, oh my goodness, this would be so much nicer to have end-of-life care at home. And this is certainly something that I've heard over the years working in ICU whenever I was in an end-of-life situation with a patient, where families said, oh my goodness, this would be so much nicer if we could do that at home. And I also want to say on that note, we have done 2 one-way extubations at home, right? They were actually for pediatric clients, where they went home with the breathing tube and we extubated them at home for palliative care. For anyone watching this, again, if you're in an ICU, pay attention to what your families are telling you, and probably also pay attention to your bed blocks and whatnot. You want those patients out, and comes back to what you said, Kaneez, partnering with consumers. Are we just ticking a box?
Yeah.
Or are we actually really partnering with consumers? Yeah. And are we really listening to them and give them what they want, which once again, I believe is a win-win, because once we take patients home, the cost of an ICU bed drops by around 50%. The ICU needs the bed, needs the staff, needs the equipment, and families no longer want to be in ICU. So think about the palliative care aspect as well for anyone watching this who either, has a family member or is working in a hospital in an ICU. How you could benefit, how everyone could benefit from more palliative care at home, which again comes back to what you said earlier, Kaneez, holistic care, common sense. It all comes back to that. Now, the other thing I was going to ask you, Kaneez, you mentioned, or we mentioned in the beginning, TPN. Do you have a lot of experience with pediatric TPN in hospital, or have you seen that, or not so much?
No, because the place I worked at in the US was a tertiary referral center for Louisiana, so we got a lot of short gut,
Short gut syndrome.
Yeah, so they require TPN for quite a long time,
of course,
until they have a transplant.
Right. And what did you do? What did you do with them? Did they end up staying in hospital, or was there anything in the US for them to go home? Or
No, they went home. You know what? I'm not really sure who took over the care at home, but they did get discharged. But obviously, these were frequent flyers for whatever not. There was always high infection rates. The Broviac was infected, and so in and out. It's not like they went home and stayed home indefinitely.
That's so interesting, Kaneez, because I'm glad you mentioned this, because we would have done now over the years 4 or 5 home TPN clients, right, and including pediatrics, the mixture of pediatrics and adults. And we never really had a line infection. Again, it comes back to what I'm saying. Our clients stay home predictably, right?
Yeah.
Whatever the support was in the community, maybe there in Louisiana, Kaneez, I argue it probably wasn't good enough.
Yeah.
Otherwise, they wouldn't have
exactly
bounced back. So the only time our TPN clients really go back to hospital is if they have an elective line change.
Mm-hmm.
And that's really the only time they go back to hospital. So that is definitely another avenue for people. Other TPN we've done, talking about palliative care, we've also had people at home with TPN for palliative care, because it was usually for gastric CA, gastric cancer. They could no longer have any oral intake.
Yeah.
And in order to prolong their life, they went on TPN and went home and had palliative care at home. So I'm just putting out some options for anyone watching this, what options are out there. Think a little bit outside of the box, depending on your circumstances, what is it that you want, and also with TPN, in case anyone is wondering where's the funding coming from, again, we have NDIS funded TPN clients. Now, you might also have private health insurance, right, if you're watching this, and you should also talk, or we can talk to your private health insurance. Again, we believe it's a win-win situation. The health insurance is paying for a hospital bed. Home care, generally speaking, is much more cost effective. So once again, it's a win-win situation for everyone. Okay, and Kaneez, you mentioned the other day, we've heard through our network, there was a client in hospital who hadn't been showered for about 9 months, and from my perspective, our clients at home have a shower whenever they want to, right? And in hospital, they often don't have the time. I don't think it's so much, they have showers and ready-made shower, special built showers for patients. But I also believe that staff in hospitals are so run down, so short-staffed, things that a healthy person takes for granted does not happen, and again, in the comfort of your own home, things like that we can do on a day-by-day basis, because we tune in with your needs, with the family's needs, with the patient's needs, and quality of life will only go up from there.
Yeah, exactly.
Now, another thing that I wanted to talk about, from a pediatric point of view, yes. Here in Melbourne, we've looked after 2 toddlers in the past that were premature babies. They spent their first 12 to 18 months first in the NICU, then in the PICU. initially they ended up with a tracheostomy because they had lung disease, because they were prematurely born babies, spent their first year in NICU, PICU, and then we took them home. And on CPAP, they got wind of the CPAP. And then about 6 months later, they got decannulated, right? And then now, because we're still hearing from those families, those kids are now living normal lives, So for anyone watching this who has their child in NICU, PICU, doesn't know what the next steps are, talk to the ICU, talk to us to make that transition home possible. And again, I can assure you that the clients that I'm talking about, they were NDIS funded. So, sometimes hospital may not even know about that avenue. We've seen that again. So think about what's possible for your child if you are in a situation like that. Do you have, you want to add anything there, Kaneez? Have you seen kids in NICU?
We have looked after kids in hospital for, we've celebrated their first, second birthdays, and definitely those kids, a hospital can only do so much. If you're enclosed by four walls, your social, cognitive, emotional development will all suffer. So, I argue that if they can be at home, that development will be different.
It will be very different.
Take them to the park. You can take them, like you said, day programs. The nurse just accompanies them so that they're safe. But I don't think it, there's always going to be because of the disease process or whatever is going on, there might be a backlog, but it would, not a backlog, a delay in development, but it's certainly not because they're sitting in one room all the time. And I would even argue for your frequent flyers, maybe they do get discharged, but, within a couple of months, they're back in hospital again. We can definitely keep them out of hospital. We know this.
Absolutely.
So, yeah.
Okay, that's great. And also for the families, again, those families would have spent the first year of their child's life in and out of, living in ICU, so there's that added on benefit as well. Okay, Kaneez, I am conscious of the time. Any final words?
No, not really.
No, that's great. Now, look, we are very privileged to have you on board.
Thank you.
You've already made a big difference for our clients.
I'm really enjoying my new role.
Thank you. Thank you. You've already made a big difference to our clients in New South Wales, but also to the staff. Also thank you to our staff in New South Wales that work with you very closely. You're already making a big difference, and we want to keep growing the environment in New South Wales and helping more and more clients. So thank you, Kaneez. Now, I want to wrap this up. So if you have a loved one in intensive care and you're looking for solutions for home care, please contact us. You might be watching this and you might be a patient yourself in ICU. Please contact us, ask your family to contact us. If you're an NDIS support coordinator and you have participants that are looking for nursing care, but you're unsure about how to get nursing care through the NDIS, I encourage you to contact us as well. We know all about the advocacy side of things. If you are a critical care nurse and you're looking for a career change, we currently have jobs for CCRNs in Brisbane, Sydney, and Melbourne. Please contact us. If you're an ICU specialist, ICU consultant, and you're looking for a career change, we are currently expanding our medical team as well. If you're an ICU specialist, if you're a nurse manager in ICU, if you're a hospital executive, and you have issues with bed blocks in ICU, in ED, please contact us as well. We can help you to eliminate some of those bed blocks. Now, if you enjoy these videos, subscribe to my YouTube channel, click the like button, share the video with your friends and families, and leave your comments on the blog or on the YouTube channel. Thank you so much for watching. Thanks, Kaneez, and I will talk to you very soon. Take care for now.
Bye.